So, good afternoon, everyone. Thank you for attending this session, and our challenge will be to try and overcome your postprandial hypoglycemia so that we can keep you awake. My name is Michael Aratow, and I'll be your moderator. And let me explain to you what the format's going to be, which will be very similar to what other panels have been. We're going to take 5 minutes each for our panelists here to introduce themselves, give a quick background, and then to tell what their respective companies are doing, and then also to talk about what they think is interesting in the intersection of artificial intelligence and other innovative digital health or non-digital health technologies. After that, we have a couple of questions that we've talked about that we're going to discuss, which we think would be relevant to this panel. And then in the last 15 minutes or so, we'll open it up to you all. And you can ask the panelists anything you want, as long as it has to do with AI and technology. So anyway, just really quickly, I'm the moderator, so I'm just going to be asking the questions, prodding them, and et cetera. And my background, real quickly, is I'm an emergency physician, still practice. I'm also a chief medical information officer at a local integrated delivery network here, a small one. And I'm also the chief medical officer and co-founder of Ellipsis Health, which uses voice analytics and artificial intelligence to create behavioral health vital sign. So with that, I'm going to have John start off.
Okay.
I think you want to
Start off with the microphone.
It's on.
Okay. My name is John Cornwall, and I'm the co-founder and CEO of Bioelectronic Health. It's a spin-off between SRI International here in the hood, in the neighborhood, and the Feinstein Institute back in the East Coast. My background is, I started off actually writing software for the Apple II. That's how old I am. And I got tired of coding in 6502 assembly and went on to Berkeley and got an undergraduate degree in biophysics, then a master's, and went off to Genentech and went to some gene therapy startups, immunotherapy startups, went into venture, went back to business school at Columbia, and anyway, fairly tortured path. But I ended up at SRI a couple of years ago, the ventures group, specifically to try and create a company around an evolving technology categorically called bioelectronic health. Some people have coined it electroceuticals. The idea is to use AI to essentially decrypt the natural language that is primarily what we're going after, those efferent and afferent signals on the vagus nerve that connects, simplistically, the brainstem to a lot of organ systems. And it acts like a data bus. And we treat the human body as a machine, as a system. We treat the vagus as a data bus. And we use massive data crunching tools and AI to essentially learn that language. And then we can spoof it, we can overwrite it, and basically what we're doing is developing ways of using electricity to replace standard pharmaceuticals. You know, get rid of PK issues, you're able to create closed loop systems. There's a lot of benefits. So that's essentially what I've been up to. Thanks.
Fran?
Hi, good afternoon. I'm Fran Ayala-Samiajula. I'm from HP. Beginning with a little bit of my background, I started my career in epidemiology and in public health, and worked with the World Health Organization, specifically PAHO, the Pan American Health Organization, along the US-Mexico border at that time, looking at communicable diseases, and then transferred over to focus more on non-communicable, specifically in chronic disease states. Worked for the CDC for a while, that wonderful MMWR for all of you readers and users of that for your research and grant submissions. And then from there, did a lot of work with the biopharmaceutical industry. In fact, became an expat for Bristol Myers Squibb, working in the Asia Pacific markets, running their e-business within that region of the world. What was most interesting is that at that time, within the late 90s, we began to see this recognition of a need to bridge two worlds between the healthcare and life sciences arena and the technology arena, and bringing those worlds together, having individuals like myself who could speak sort of both languages, if you will. Use that to come sometime 4 years later, coming back to the US market, and was for a small stint actually the director for heart disease and stroke prevention for the state of Tennessee, amongst other things. It's been within the last 7 years that I've actually worked for HP, and people always ask me so commonly, what is HP doing in healthcare? So I will use this to let you know without trying to give it too much of a commercial spin to it, but HP has been in healthcare for over 50 years. So if you think back to cardiovascular ultrasound, that was an area that HP was in for a long time. If anyone remembers a company called Agilent, which is a medical instrumentation company, that was HP. We spun that company off in the late 1990s. I think it was actually 1999 when they were spun off. But HP, as it changes over the years, and many of you, it being right here in your own backyard, would know it's changed over the course of many years. It continues during the course of that time to nonetheless invest further into healthcare. And so that's what we have done today. We are continuing to do many great things. When we think about the sequencing of the first human genome, that was done on HP compute power. But going beyond that, there are other great examples. Bio inkjet printing would be another great example where we take the peptide process and actually automate that. If you think about it, that's a very highly intense type of technique that's required and requires individuals with very high skill set. And we've been able to automate that with greater degrees of precision. So it's really exciting, but there's a bigger world out there of what we're doing within this environment that's even more exciting. And some examples of that are creating purpose-built technologies that are used directly with providers. The other thing that we're doing is a lot within virtual reality and mixed reality, which I'll share more about actually during the course of our conversations. And another really fun area that I'm sure is in the back of your minds, because HP is known for print, is 3D print. And so when you begin to think about how the world of artificial intelligence can be leveraged within the context of healthcare, think about prosthetics as an example, where we can embed chips into arms or limbs that are produced, and be able to get intelligence off of those, and further use that not only to tell an individual how well they are being able to adopt to that technology and adapt it as a part of their own personal ecosystem, but also be able to prevent failures from those devices, so we know it ahead of time and are able to create for preventions. So there's a lot of cool things, and there's no limit of where we can go with many aspects of technology, and this convergence of it is the most exciting. So looking forward to the rest of the conversation.
Thanks. Jim?
Great, thank you. My name is Jim Stefancic. I'm co-founder, president, and CEO of Raven Healthcare. We're based out of Nashville, Tennessee. And my background is I have a PhD in biomedical engineering. Actually, I commercialized my PhD work, which was in image-guided liver surgery. So I went from image-guided liver surgery to mental health AI, mostly because of my passion for technology transfer. So how do you take some of these technologies that are buried in the academic or the non-for-profit sector and get them to market? And I was fortunate enough to meet up with the folks at Centerstone when I exited Pathfinder, my first company. Fortunate enough to meet the folks at Centerstone, one of the largest providers of community-based mental health, who had built their own data warehouse over 14 years, had a tremendous amount of data, and some really exceptional data scientists that were working on answering the real question they wanted to know with mental health AI, which was not only who is at risk, but how do you best treat them over time at the lowest cost. So yesterday, the keynote speaker talked about ways for healthcare. That's really what we do. We show different pathways of care, some of which may be obvious and some of which not so obvious, and which one's going to get the patient better, because healthcare really is a sequence of events. It's not just, hey, there's a 70% chance this will work, let's do that and hope for the best. It's maybe you do this for a little while and then you switch to something else. And what is that going to look like over time? How much is that going to cost? And so this technology really, my co-founder Casey Bennett, exceptional data scientist, he really started looking at this back in 2011, published a paper in 2013, kind of the seminal paper on the technology. Venture capitalist, Coslov Ventures gave him a call. He's at Indiana University getting his PhD, working part-time for Centerstone, and he's like, I don't know anything about starting a business. And fortunately, Indiana and Centerstone, locked down the technology and the software, which I came in then, and we spun off the company in 2016. So we're really excited about some of the things we're doing that I'll share with you over the course of the conversation. In terms of where I see AI in the future, we've talked a lot at this conference, I've been in all these sessions about a lot of the interactive ways that AI work. We're actually thinking about it also from a passive way, meaning what about socially assistive robotics in the homes of the elderly? So what if you put a robot in there that's like a pet? There's a robot called the Paro robot. And if you've ever seen this thing before, you might look at it and be like, this is crazy. But in Japan, it's huge because they love robotics and they have so many elderly people that have suffered from chronic loneliness. What if you could put sensors and other things on that device to understand whether someone was in a state of depression or moving towards depression, and could you predict that and then try and prescribe what's the best thing to do for them? So we've done a pilot study where we're collecting passive data from some elderly people in Indiana, and we've been able to, it's only N equals 15, but we've been able to predict whether or not they're headed towards depression just based on the way they interact with these robots. So we are really excited about what you can do with AI, not just make robots that are going to open cans of soup and help people get dressed, but starting somewhere like with the passive robotics, putting something that's easy to do in the homes of the elderly and have them interact and get data from that.
Great. Fran, so sort of taking Jim's lead there in terms of extrapolating out in the future, he checked off one of the AI plus one of the trendy buzzwords is robotics. So I know there's some other ones like VR and AR. Maybe you want to talk about that or some other buzzword that's out there that I can't think of right now, where you see where AI might be able to,
Well, sure. First, I'll start off by, fortunately I didn't have a lot of copies, but I put a couple of copies of the AI in Medicine journal on a few of the tables, so it's not a piece of trash, it's actually some good information. Don't toss it, take some time and read about it. It's not HP work. It's the work of a new group that's starting, that's emphasizing some of these values, practical values from a medical perspective. But just really quickly on the VR side, we certainly are seeing some applications there, and I think that Walter Greenleaf did a great job. I hope you all were able to see his presentation as he referred to at the end, what is sort of, at the end of his presentation, what is just the beginning of what we are seeing and what we're going to see in terms of the application of artificial intelligence in the virtual or mixed reality environment as we begin to leverage the information, be able to look at how individuals are responding in such types of environments. A great example is in chronic pain management, sort of where we began with some work that we're doing at Providence, and essentially using biofeedback information on patients, but being able to span far beyond that in terms of data gathering of what can be deduced from the responses and of individuals as they are interacting within an augmented or a virtual reality. And the benefits of that are quite unique, but I think there are also some challenges that can arise within those environments for which we need to make some take some precautions for, but definitely some huge opportunity.
Great. John, do you have some like AI and CRISPR, or I know really?
Yeah, I mean, I think the biggest, what's really struck me in the last couple of years are things that I never thought would ever come to fruition, that it was snake oil, all these predictive healthcare and all the rest, that you really couldn't get actionable data out of a biological system. Well, you can, and it just you just need a lot more data, and in these days the computational power is there, sensor technology is evolving. I mean, yesterday I think someone discussed the smart city, the smart town. I mean, we're all smart bodies. There's a lot more wiring in the human body than people thought. It's not just all hormones and diffusion. I mean, even the immune system, not in just stress response. But even things like antigen trafficking there's neural components to that feedback system. And as we decrypt these things, we're going to gain a lot more knowledge about how people behave and also their failure modes. And that's good and bad. I mean, everyone's concerned about the leak of their genetic data, like doing 23andMe, that for all time immemorial, everybody will have access to your genetic code. Well, this takes that a step beyond. This is where, I mean, potentially you can have a real-time data out on you. And when you start seeing sensors being implanted for other indications, you're going to be collecting collateral data. Basically, everyone's going to be walking around with a black box in themselves within 10 years. It's like if you get in a crash, like let's say a Tesla, Teslas, you've heard about these famous crashes. That's AI, right? And so everyone's looking for blame and, basically a liability suit. But you can have the court, you can petition the court, and they can go to Tesla and they can force them to cough up the black box data from any car in a car accident. Pretty soon, you're going to have to face that issue. If you got in a fight with somebody, or there was you murdered somebody, if it was is it murder 2, is it murder 1, was it premeditated, were they stressed out, what was their cortisol levels? I mean, it's good. It's a brave new world, and it's not very far off. It's going to be crazy, and the analytics are there now. It's just a matter of kind of getting over that activation energy for people to actually get the sensor arrays in us. But when that happens, all bets are off. It's going to be a brave new world.
2 words, Minority Report.
Well, still in this brave new world, I'd like to ask you a question, how you feel about sort of the acceptance of this craziness now to be coming in the healthcare industry right now, and what have you experienced, now? What do you think we're going to experience in the future? I mean, we're starting off with, we're just at the tip of the iceberg, right, with the AI, and so, like you said, the possibilities are immense, and so how is healthcare going to take that? I mean, how are the people in the industry going to respond, and how are they responding now, and how do you think they'll respond in the future? And what's the best way to bring it into the healthcare industry to make sure that it's done in the most correct and unexploitative way possible? Jim?
Sure, yeah. So I think the key is to start small with a lot of these projects. So when Casey first worked on this technology back in 2011 at Centerstone, he was working with clinicians, working with computer scientists at Indiana. It was really exciting. Everybody saw the value of what they were doing. They published a paper that said you could, for patients suffering from diabetes and depression, if you do AI treatment versus treatment as usual to treat the depression, you get 40% better outcomes at a reduction of cost of 40%. Great finding, scientifically valid, wonderful paper, lots of press. Buried in there, though, it said part of the reason you got better outcomes at a lower cost was for some people you would do nothing. The right treatment is to do nothing. Do less, you get better outcomes. You overtreat mental health, you oftentimes get worse outcomes. So the clinicians were happy when this is done in a controlled environment, but you're not going to go to a clinician at a community-based mental health facility and say, stop treating this person, they won't get paid, they won't get their 3% margin. So, it all has to do with the environment you're in, fee-for-service versus value-based care. If you're trying to address, 2 legs of the triple aim there, it's a big deal that you have motivated customers, motivated people in that environment. And really, the time wasn't really right for that. With the advent of the ACO model, where value and value and outcomes are important, we've seen that. We've definitely gotten some traction in that space. We still get a lot of pushback from clinicians. Even though we explain this, it's a GPS. If you're driving through San Francisco, you don't like the way the GPS is telling you to go, you think there's a better way, go that way. You don't have to follow what we do. It'll still learn the decisions you make. Now, you're never going to tell me what to do, you snot-nosed PhDs, get out of my office. But my case managers, I don't know why we have all these case managers. I don't know what they do all day, we pay them all this money. You go to the case managers and they're like, we're starving for something like this because we're overwhelmed with mental health patients. We can't do everything for everybody. We need technology to help us, give us the technology. So you got to find the right end user and you got to start there, and then you can start to move into the other disciplines.
I would add on to that you build confidence over time, right? And we're seeing some areas in which confidence is being built very rapidly. A great example is in medical imaging, right? There's some consistency within that particular controls within that environment, which make it fairly easy from an AI perspective to be able to apply the technology and be confident in the outcomes that are being derived from it. And so with that, it builds confidence as we're able to demonstrate areas in which it can practically be utilized. The other thing, just kind of piggybacking off of Jim to some extent, is while you didn't choose the word collaborative, it's a collaborative process, right? You listed out some key stakeholders who are part of this, and so it's like going through this journey together. So that it's not just a bunch of researchers on the back end who are making all of these decisions, but it's actually incorporating the thought and also helping to define the role that the clinicians themselves on the front line play within the process of the adoption of the technology. And then thirdly, I would say that it's also a generational thing, right? It's an evolution, it takes time. And that's true with any type of technology. I can't probably think of one right now because it's been time when we've adopted to whatever it is that we have today. We take the technologies that we have in front of us, even the microphone I'm holding, for granted. But at the end of the day, that really makes a difference. So what we see as an example is while for those who are in practice today and have been in practice for a long time, it may not necessarily be as easy, but for those who are in the institutions learning today, the medical students and other clinicians who are being exposed to this as a form of their education, it will become an expectation. All of these advances that we are building in our so-called basement labs, right, are the expectation as they get introduced within the context of their curriculums. And virtual reality is a great example of that, where now students are being trained with those technologies. And when I say virtual reality, I just don't mean immersive experiences, right? I'm even referring to the use of holographic 3D imaging, in which we're able to look at 360 views of technology, taking the average 20 terabytes of medical imaging data that a hospital produces every year and actually being able to view it and do something with it. And that's astounding. And the students who are coming out of these medical institutions today are coming out with certain expectations. And then for those clinicians who are in practice today, the expectations of their patients are being altered as they're being exposed to technology. And the way that they practice and the way that they are embracing and utilizing the technology in their environments is a determiner as to what degree of confidence that their patients even have in the way that they perform. And we've seen examples of that in many institutions, even across the Eastern Seaboard, where we have no-show rates that are changed based on certain groups of patients being allowed to be in environments where these institutions are adopting the technology for complex surgeries, as an example, and they've seen their show rates improve by 25%. And we definitely attribute the use of the technology, the use of AI and other forms of technology as one of the key contributors to why even the behaviors of the patients and the expectations of the patients in regards to the medical community is changing. And if nothing else, that will force many providers to embrace it, whether they're ready or not.
Yeah, speaking of curriculum, I think Carnegie Mellon has now a new undergraduate degree in AI. They just announced. So, John, you have anything?
Yeah, I think at least in the area of AI that we're working on in terms of trying to regulate physiologic functions, I think one of the big drags that are slowing it down will probably be the regulatory paradigm surrounding it. You know, people are used to developing devices, in traditional pharmaceuticals and biologicals like monoclonals, but when you have an electrical signal, essentially, it's almost like you're dealing with an iTunes store instead of a pharmacy, and that brings up all the other issues about reimbursement. How do you electronically prescribe something? You know, if you withdraw an electrical stimulus therapy, suddenly there's no PK, there's no washout, right? You start taking something that treats an arrhythmia, you will have some warning that you made a bad decision. If it's an electrical stimulus, it's just gone, right? So there's this whole nexus of issues that that will need to be addressed in order to replace traditional pharmaceuticals with an electrical stimulation regimen. And then you've got to have a way to apply multiple stimulations concurrently, and how do you do a clinical study like that? I mean, how do you have naive patients? What is a naive patient? So it's a whole different paradigm. A lot of things are going to have to get worked out.
You said we have 15 minutes? Okay, sorry. So let me ask another question now. Considering this is a common good conference here, and as you people know probably, a lot of the research that's currently done in the healthcare is sort of from a homogeneous type of population. And there's a lot of populations that are not represented, and therefore you cannot extrapolate a lot of the research, and that's why it's not reproducible in a lot of contexts. So I was wondering, since there's a report that came out from Meter for the government that talked about healthcare and AI, and they were talking about the need for more data and to get more labeled data sets to train the models, et cetera. How do you think it's going to play out in at least in the initial AI evolution here? Are we going to still introduce the same biases that we have in our medical literature into our data sets, that are labeled data sets that are driving the models? And if so, or how do we combat that, considering it's very challenging to get data in the first place, and sometimes, especially from underserved populations, it may be even more challenging to get data from them. Who wants to take that first?
I'll let John talk for it.
Thank you for that.
I don't know if you're going to like the way I respond to it, but I'll go for it. And the reason why I say that is because it's not just all about the data, right? And it's not all about the clinical environment. The clinical environment only constitutes, 20% of the determinants of health outcome. And even when we look at genomic sequencing, when we try to make all these predictions based on what someone's DNA and what the indicators are based on their DNA, well, we know that it's not just that sequencing that's a determiner, but it's the epi components of that can make a difference, which means their environments influence that. And so I think that in that context, there's sort of two elements. Number one, yes, do we need to have diversity amongst the groups from which we're collecting, creating these data sets? Absolutely. But also making sure that we're asking the right questions when we're working with that data. And then equally that we're looking beyond just the data points itself and looking at the other elements that are contributing to the current circumstances and what will lead hopefully to the better outcomes for those individuals. Some of the groups now their name is I had a blank on the name, but there's Audacious. Audacious Inquiry is a great example of a firm, doing a lot of work in AI and their involvement. It doesn't end with the data. In fact, it doesn't begin with the data nor end with the data. It begins with the patient and actually taking time to talk about the patients, not only their symptoms, but the environment that they're in, right, that might be contributing to their condition. And then beyond that, coupling it with the data, looking at the other elements that can be used to determine the betterment for that patient and the better management of their condition, which may have absolutely nothing to do with the general biometric data, as an example, that might be maybe collecting. So I think this goes back to redefining what we mean about the application of artificial intelligence and data, as well as going back to the conventional definitions around population health and population health management, which is based on not only the use of good data, but also the use of good data in the context of programs that are designed to serve the needs of an individual, which contextually has a lot of other elements that needs to be looked at, examined, and modified. And it can be everything just as simple as the living conditions they're in or the choices that they are making, and not just about the current disease state itself.
I can elaborate a little bit more. I agree 100%, Fran, with the idea that you got to ask the right question. So we spend when we engage a customer and we haven't figured out exactly how to do this yet, we're still in a lot of customer discovery. One thing we have learned though is that you've got to ask the right question. And because we're subject matter experts in mental health, we can come in and start to ask them questions, and all of a sudden we'll find one that's a pain point. This is a pain point for us, yes. We're trying to improve these outcomes. Maybe so they'll get paid, maybe it's so their patients will end up better, they'll get higher scores, whatever. Hopefully it's a combination of all those things, because that's what's the best for the organization and the people they serve. And these are organizations that are treating some of the sickest of the sick, so in mental health, so they're very compassionate. Then the idea is to get as much data as you can. And the thing about optimization versus deep learning, we do machine learning versus neural networks, is you're trying to optimize the answer. You're not trying to categorize, you're trying to optimize. So, you may not have all the data available to you when you start this process. We try and find the 10 or 12 key variables. We consistently tend to find those variables in the data that can help answer that question. So some of them are social determinants, some of them are physical. Obviously, if we get a sense there's more social determinant variables, the organization can start to think about other data they can get from their members. Then they start to really think and understand the power of the technology. And so we like to start with asking the question, and sometimes that takes longer than actually running the data through the analysis and doing the mathematics and getting some sort of answer and explaining to them why it's accurate or not accurate. So that's really been our focus. And obviously the fact that we're subject matter experts, that's the other thing. This isn't, you just don't throw data at a model and hope for the best. You really have to work with people that are subject matter experts when you're working with this kind of technology, because it can be dangerous.
Yeah, so the applications I'm working on obviously don't have the social inputs, but overall I think AI has the best chance of enabling true personalized medicine. I think standard of care is almost by its very nature, it's the least common denominator approach to something. And there's been in the last few years an attempt to expand drug testing and try and get a more representative population to develop treatments in. But ultimately, it comes down to how's the individual responding. And traditional treatments and pharmaceuticals is kind of a guess type process, right? You prescribe a drug or you do a treatment, you follow up, you see where you're going. It's not a random walk, but it's a directed random walk, if you ask me. And if you use AI, we can really understand the body as a system, and you have the inputs, and you have enough data, and you have some rules, you can customize that framework to an individual. And then if you get the polling rate's high enough, you can eliminate some of the random walk to it, right? I mean, you can drive somebody towards the outcome or the parameter or the health status you want. And, again, there's a lot of people working in this field, and this is, I think, what we all want. Your car, right, you're not going to go and tweak something and drive. This is the way people used to, tweak Model Ts, but now cars have, 40, 50, 60 microprocessors in them that are monitoring parameters, predicting failure, aircraft engines, right? Tons of data coming off these things. I mean, we're more valuable than a turbine when it comes down to it. We just haven't gotten there on how to instrument ourselves, but when we do, we will be predictive and we will be treated like systems. I think that's a good thing. And I think it'll inherently take care of the intrinsic bias that people have socially and in terms of what groups are treating and all the rest. You'll get rid of the need to aggregate people into categories. You'll treat everyone like an individual if you've got good enough data and algorithms.
Great. I think now we're going to open it up to the audience. So I don't know, there's someone there with the microphone, and fire away your questions.
Hi, Arthur Keller from Psychanalytics. One of the issues that is with AI, especially with so-called deep learning, is that, and in some of their AI systems, is the inability to explain why they made a decision. And I think that may be a barrier to adoption. particularly in the event of an adverse outcome and the unhappiness of your malpractice insurance company for whoever adopts it. So I'm wondering whether these issues will lead towards better explanation systems, or whether these issues will lead towards the type of AI that might be adopted so that we can have explanations. And I'd like to hear your thoughts about that.
I'll just give a really quick response on this one, I promise, and that is around definition. I think one of the problems is that within AI currently, if we think about it, there's still a lot of concepts within medicine itself that haven't been clearly defined, for which there's still debate, even in the terms of what is, or what type of outcome even is the acceptable outcome we're trying to achieve. And that contributes to some of the challenges that are there, and as a result, you're going to continue to see this kind of inconsistency in terms and questions and uncertainty and lack of confidence in the decisions that are being proposed through AI.
Yeah, I think for us, obviously you get a computer scientist in the room talking about ROC curves and p-values and things like that. It's going to go over a lot of people's heads. People understand accuracy, they understand false positive, false negative. We try and show them that. We try and tell them, because it is really hard to get into the black box, you're right. There have to be ways to do that. We have to think about those ways. What we try and do is say, okay, this is what we did with all your data. This is why we think this model is the most accurate, and why it's going to generalize to your population. We're very, very focused on that. Sometimes we'll get very accurate results, and we just don't believe it's going to generalize to the population. So we say this will not work. It may be 85, 90% accurate. We don't think it's going to generalize. So, and here's why we don't think it's going to generalize, because of the way we did the ensemble learning or the cross-validation. Try not to get too technical, but explain how we looked at their data. I think trying to get into what's going on in the black box is going to be more challenging. We're trying to take the approach of this is what we think, and even though it's a high number and we can brag about that, in our expert opinion, we don't feel like this is a model you can use, and we try and be true to that. And that's one way to get around this, I think, in the short term.
I believe as we move into therapies that have more descriptive statistics and confidence intervals, I actually think it'll reduce malpractice, right? Because right now you get a jury and it's totally an emotional decision, often subjective. When AI-driven therapies are, I think, submitted for approval, I think the FDA is going to devise a framework where there are some nominal confidence intervals required, and if they meet those, you basically are going to be in the clear. I think people will understand that there's no such thing as a perfect decision, and I think AI and the more descriptive future of medicine, more statistically based, will actually help some of these things. Right? I'm hoping at least, right? But it should make it easier for people to understand that there is no perfection, and hopefully there can be hard and fast thresholds for when you can litigate.
I believe there's an organization called OpenAI, which is a collaborative of all the large Google, Facebook, etc., who is trying to establish standards, right, to sort of describe what's in that black box, to sort of open it up, like you said, so you know why those decisions are being made. I don't know if there's a specific, I haven't followed it, so I don't know if there's a specific healthcare portion of that organization, but that's something that can look into.
And the FDA is starting to publish documents now on clinical decision support. So if you Google that, you can read, I think it's in the recommendation phase right now, like the public phase. So I think there's going to be a document, as John mentioned, that's going to get into some of the details that have to go around this. They're going to be treated more like medical devices there's going to be an indication for use, and you're going to be held to that standard by saying it's an aid. It's not making decisions, it's an aid. It's to help make decisions.
Other questions? Really?
I think going off that right there, something that I kind of find interesting is looking at GPS, right? When kind of GPS first came about, people would kind of use that just like maps or, kind of printing it out from MapQuest. And looking forward, especially, the millennial generation and younger, GPS has become such a part of how they get around that they can't actually navigate around their own neighborhood without. How do you see this kind of applying to doctors using clinical decision support versus actually determining, no, a doctor is going to just take that determination and not actually use their medical training?
Well, I think it's in the word aid, right? So as we accept AI as a tool and CDS as a tool in the context of practice, it's an element of assistance. It's one more tool within your toolbox. It is not the indeterminer. And your training and your experience over the time is the thing ultimately at the end of the day which you have to fall back on. We go back to the initial questions around liabilities, right, and the risk that it poses to one's practice. Then AI is a tool within your toolbox, and you've elected to use that, and you have justification why you chose that tool or the other tools that were at your disposal in the process of treating your patient population.
I think another thing to consider is the idea of evidence-based medicine versus practice-based evidence. So, doctors in the Southeast come from schools like Vanderbilt, Emory. They're trained differently than doctors in the Northeast that come from NYU, Columbia, Harvard. They have different ways of doing things, and I think that's, I don't know how this will affect it. I wish I could predict what would happen, but they're always going to be trained to do things a certain way that may be slightly different, but they're helping their patients, right? They're working with patients. They're obviously, if doctors were wrong, most of the time we'd all be dead, right? So they get it right most of the time wherever you live, and they're doing things for you. So I think it may somewhat tie into how you train, where you train, how you use these kind of algorithms. And I think there's always going to be that human factor, the empathy factor. I think that's never going to go away in medicine. It can't, because from what we've heard from all the speakers here. So I think all those things will be important, but I think Fran's right, it's going to be a tool in their toolbox, and a lot of the young clinicians I talk to, residents, fellows at Vanderbilt and things about this technology, they're like, we're anxious to have that because we know what we don't know, and we think it's going to be very helpful for us to get up to speed on things. And so I think they're very open to it, but they also know they're going to learn things that an AI is never going to help them do.
I think overall it will improve the accuracy and the efficiency, so it should give caregivers more face time and maybe might actually help in terms of establishing the more social inputs. But I've no doubt that there'll be some clinicians that will get lazy from it, right? I mean, there was a crash at SFO a couple of years ago where these guys are almost always on autopilot, and there's been a lot of criticism that a lot of pilots don't know how to really fly by feel anymore, that it's always pressing buttons. It's like a video game. And I imagine as more tools come, human nature is that you rely more on them. I'm sure there'll be some cases where people miss things because of it that the algorithms didn't catch. But I think on balance, I think autopilots save a lot more people, prevent a lot more accidents than they cause, and I think the same will be with AI-driven predictive healthcare.
Yeah, speaking as a clinician, I think I agree that there's going to be some people who will just slack off and try and pawn the effort onto the AI. I also think that AI will help sort of shift care. If you look at one end of the spectrum, you have the specialist, and at the other end of the spectrum, you have the patient. And so AI is going to start allowing people to practice more to the top of their license, as they say, so that you'll empower the lower rungs as we go from specialist down to patient, and so the patients will become more empowered, and they'll probably not go to the providers for things that they go to now. For example, sexually transmitted disease, which you can get treated online now for, sore throats, urinary tract infections. And so AI will start helping empower the patient, and they'll be doing some more things. And the role probably of the provider will change somewhat. But at the same time, it was also brought up by all the panelists, which is right, and it sounds like from the rest of the talks, is that human factor, that connection, is going to be really important, because sometimes people, they have problems, but sometimes they just need someone to talk to, right? And so that human may become more important and may actually make practice even more human. Another question? I think there was someone over here. Okay, is there, who's got those mics? Oh, Walter.
Yes. I'm looking forward to, we don't use the term digital medicine to talk about the new things coming. I'm wondering with AI in medicine and AI in general, do you think it's a term that will persist? Or do you think it will, right now when I do a search on the web, there's an AI system assisting me and I don't think I'm using AI. Do you think this will be a separate category and persist for a while? Or do you think it will sort of merge with what we're commonly doing?
I wish it would go away. Because everybody says they're doing AI. I'm using AI to make a grilled cheese sandwich. Well, you don't need AI to make a grilled cheese sandwich, and you're not using AI anyway to make that grilled cheese sandwich. So we had to have AI in our name because everybody said we did, even though we don't really do AI. We do machine learning. It's different. I hope it once again just becomes part of the standard practice of medicine. That it's, you're going to take these courses on the value of this technology, however it is, like EHR, whatever value it has in your practice and for what you do, and there's standards that have been applied, and it's part of becoming a doctor is understanding how to navigate the technology and use it to do your job better. That's what I hope. I don't know how long it would be, but it doesn't seem like it's going away anytime soon.
I would agree with you on that.
I totally agree. Buzzword bingo. It's you have to drop that name to get funding. So.
Thank you again for your time here on the panel today. Always interesting hearing the latest perspectives about AI. It seems that we're really at a new forefront and convergence of AI in healthcare. There's a lot of hype, excitement, and we're still at this point of looking, retrospectively around looking at data and metrics that we know are indicators of healthcare, and let's, look deeper. But ultimately, then there's a lot of forward-looking excitement around AI and its ability to be predictive and lead us into new horizons of healthcare. But that ultimately requires a lot of research, a lot of investment, money, things like that. So I'm curious about the panel's perspective, given some of these investment timelines, horizons. How are you and your representative organizations looking at that balance between investing in AI versus maybe needing quarterly numbers, and headlines and things like that, and just the approach to that?
Well, no one thinks it's sexy that I tell you that we are applying AI technology to look at your behavior around your computer, right? But we do. I mean, that's an area, right? So there's always going to be that balance from an investment perspective. Those things that make the headlines and that are exciting, and we will certainly look towards those. But if I apply that, then turn that around and sort of back to healthcare and what we're trying to drive in terms of healthcare and healthcare itself. We also, if you notice, we have our themes in healthcare. And so in the context of that, every year there's a new theme. This year, it's the opioid crisis is a big one, right? And for good reason. Stroke for a while had its time, and oncology, everything gets its season and its attention, and we drive towards putting investments in certain areas, and we put big bets on the technology as it applies towards the benefit or the desired outcomes. And so I think to that end, we're going to continue to see a big push within AI, and nothing happens without it being evidence-based application of the technology, because that's what's going to ultimately drive towards, standard of care changing, right? Modifications or improvement in protocol changing. So the research drives us towards that, so the investment in the research will continue to happen.
Any questions?
One more.
One more. We got one more.
You mentioned the FDA earlier. I was just wondering, what are your insights into what is the FDA doing about this? Like, what's the future state for the FDA around this?
Right. So they're they're starting to, under the Trump administration, I know they're starting to look more at digital health. It's become more of a focus. They're looking specifically, I think the term that they're using is the clinical decision support. That's what I believe is, if you were a fly on the wall there, would be what is discussed. I know they're having some big AI summit at the White House. I've heard about this. So I think they're probably going to zero in on, in my opinion, having been in the device space and actually been to FDA and had to make my case for an indication that these devices are going to have some sort of indication for use. Any device that you use right now has to have a written label, it has to have labeling that has the indication for use. I think this technology, it will be required. What kind of data to support that indication for use is, I think, what is still in question. And John alluded to that a little bit as well.
So I've been on quite a few calls with the FDA, and one of the things we're trying to do is get their hands around an area that they're not as strongly familiar with, and in particular because there's so much organic kind of growth of solutions and technologies, even from providers themselves. And there are within the recommendations a couple of initiatives that are happening, one in particular in which institutions, startups are asked to be involved in the process of determining the certifications. There will be degrees of certification that are going to be created, and they're defining those right now. So if anyone is interested, you definitely should consider jumping on board, because they're looking for the community within this space to help to influence and determine, or define, if you will, what those requirements are going to be and how they'll be set.
Okay, we're over time now, so thank you very much for your attention. I'm sure the panelists will be here afterwards if you want to speak with them and have more questions. Thank you.